Hi, everyone. Biohacking Blondes here with Alex and Molly. I hope everyone's having a great day. We're super excited today because we have an incredible interview with Dr. Felice Haake. She's an incredible physician, and Alex is going to give her a little intro on her background. Alex?
Yes. Good morning, everyone. The wonderful Dr. Hockey. She works at RBI in Vero Beach. She's a concierge and age management physician, and she's also board certified in family medicine by the American Board of Osteopathic Medicine. She's a diplomat of the American Board of Obesity Medicine. And Dr. Hockey, she specializes in medical weight loss. In addition, Dr. Hockey is trained in age management and is currently a member in good standing with the American Academy of Anti-Aging Medicine. She earned her bachelor in psychology from the University of Florida, certificate of post-baccalaureate, pre-medical studies from New York University, and her doctorate from Nova Southeastern College of Osteopathic Medicine. Dr. Hockey, she has a big passion for helping patients restore their health through diet and exercise, education, hormone optimization, and nutraceuticals. She has a practice, what you preach philosophy, and truly enjoys sharing her knowledge and her everyday practices with her patients. Her focus on hormone optimization, dietary, and exercise interventions allows the patients to take control of their health and enables them to lead a more vibrant and functional life. Her hope is that with a comprehensive approach to a patient's health, she can help them become the best versions of themselves. I absolutely love it. Good morning and welcome, Dr.
Yay.
Hockey. You're a
Oh,
superstar.
thank you so much. What a very warm introduction. Thank you.
Absolutely.
Love that
Absolutely.
we love that you practice what you preach because we live by that mentality as well, and I think that that's important for when you're looking for a doctor too, to find someone who really is like walking the talk.
Yeah, well, if I'm telling you don't smoke with a cigarette in my hand, it doesn't really kind of land well.
Right, exactly. It's funny,
Yes.
I used to work at Sotheby's Auction House in New York when I was really young, and it's right next to the main hospital in New York City. And we would always go outside for lunch and we'd see all the doctors and nurses smoking in front of the building. And I'd always
Yeah.
be like, that's weird. Like, that's a little bit different. I wouldn't expect that, but it's funny you see it. So
You do.
Yep.
yeah.
Yep.
So,
So
so we're excited. We want to talk a little bit about peptides today, if you don't mind. We're
Not at
very
all.
curious. Yeah, the peptides are kind of this amazing hot topic now. Everyone's sort of using them. It's on all these podcasts. It's kind of like the rich and the famous are using them a lot. And we're curious. Will you give us a little bit of a background? So, like, what are peptides and how do you use them for your patients?
Okay, well, I love peptides. It's an adjunct to therapies. I like to look at what I do as, it's very comprehensive. I'm looking at a patient from all different avenues. So one avenue for treatment is peptide therapy. And peptide therapy has been around a very, very long time. Essentially, just to give you a little background on peptides, I think the first peptide was discovered in 1901. And then we have probably over 100 peptides that we use for actual pharmaceuticals, things you can get at Walgreens and CVS.
Mm,
But peptides are essentially small chains of amino acids, and amino acids are the building block to our protein building blocks and muscle building blocks. And so amino acids that are strung together in a sequence will make a certain type of peptide. So it's sort of like ingredients to a cake, chocolate cake versus vanilla cake. So different sequences of the amino acids will equal a different type of peptide. And peptides, usually the sequence has to be under 50 amino acids, although you will hear a debate on that all over the place. I mean, if you, God forbid, were to do a Google search, you'll see it'll say 2 to 50, 2 to 70, 2 to 100 amino acids. So there's definitely still a little bit of a debate. When I took my peptide certification course, I was taught 50 and below.
mm.
That's what I was taught. But in any event, they act very much like, and I'm going to steal this from one of my professors that taught me peptides. They act very much like doorbells. They're cell signaling agents. You have thousands of them circulating in your body. They are naturally occurring molecules. And like a doorbell, they ring the bell and they elicit a response inside the cell. And so this kind of differs from hormones in other types of molecules in the body that hormones in particular have to get inside the cell and make changes intracellularly. And so what will happen is you won't see results as fast. Okay. So peptides tend to give you pretty quick results, and you have peptides for everything. I think we have identified about 5,000 peptides in the body,
Wow.
meaning they have names to them. However, they believe there's about 20,000. I mean, they think there's even more than that. So we're still learning. If you ever look at a peptide catalog, it is huge. It's huge. And my head spins. I know the most common ones. I'm certainly not a peptide expert, but they can be used in so many different ways, from cognitive health, sexual health, to weight loss. I mean, we know the most popular ones right now, Ozempic and Mounjaro, they've been put on the mark. So they really can be used in lots of different ways: body composition, building muscle, losing fat. So that is kind of an overview about peptides. Hopefully I did a good job with that.
Excellent. Yeah, I think that really highlighted a lot of, questions that we have, and I think the listeners, right? It's yeah, that was really good. And what do you think is the most promising therapeutic applications of the peptides that you come across in your research or your practice?
Oh, there's so many. I mean, it's kind of funny. Peptides were sort of put on the map by bodybuilders. I mean, bodybuilders are like the original biohackers.
Mhm.
And they kind of were figuring out how, because their entire job was their body and how to optimize it,
Right.
from a physical, and appearance standpoint, not
Right.
necessarily internal health. I have to say, that's
Right.
probably not the healthiest profession, but
Right.
but they were using peptides. And so peptides, have so many, utilizations, from cognitive health. There's nootropics, Selenk and Cmax. Another would be, I happen to love the growth hormone analogs like sermorelin, ipamorelin, CJC. You have PT141, which actually was marketed as the first ever female sexual arousal peptide or drug. So it is actually a drug. And so you will find so many different ways to use peptides, and they are just absolutely remarkable. And here's the best part about peptides: because they're cell signaling agents and they go in, they do their job, and then they get out, they metabolize out. And so when you see drugs that have a lot of side effects, it's usually because they're going through the liver and they're interacting in different ways. These compounds are very natural, so the body sees them as self, and so it doesn't try to reject it, when it comes to adverse reactions. So you don't really see a lot of side effects from peptides. I mean, there are some, but very few.
Interesting. And so are they FDA approved, or there is some sort of back and forth on that? Like
Oh,
how?
they're definitely. So what we're talking about is just peptide therapy in general.
Yeah.
But there are absolutely, I mean, as you know, Ozempic is a GLP, glucagon-like peptide.
Yeah.
So is Mounjaro, GLP and GIP. And these are peptides that are FDA approved. Insulin is such a great example. I mean, before 1921, when insulin was essentially synthesized, when they figured out how to synthesize insulin, I mean, kids who got type 1 diabetes, they died. I mean, they didn't survive, maybe a matter of weeks to months, maybe a year. They had really kind of crude ways of keeping these kids alive. And so insulin, I mean, thank God for it. These
Yeah.
kids would never have survived. So there are absolutely peptides that you will find in pharmaceutical grade and that are FDA approved. And then a lot of the ones we're kind of talking about, like sermorelin, ipamorelin, these guys are not. They come from peptide compounding pharmacies. I say peptide compounding pharmacies because they're compounding pharmacies that specialize in peptides.
Mhm.
And they're US sourced. I mean, I always ask all the questions. And unfortunately, there's a lot of controversy surrounding peptides, regarding, are they safe? The FDA just always is kind of like beating down these peptide compounding pharmacies.
Hmm.
Right. So can I ask you what is important? So there might be some listeners that are going out on the internet and looking at their own, to buy their own basically because it might be cheaper, right? What do you say to that? And what is also why do you want to use that compounding pharmacy? Where you're saying they're getting the peptides from the US? Is that always
Yeah,
the
well,
case, or?
they're sourced in the US. So a lot of these compound pharmacies, I mean, the one we use, most doctors have to have accounts with these pharmacies. And the one we use happens to be, I'll give a little plug for them because they're phenomenal, is South Lake Pharmacy out in Fort Myers. They're excellent. And so I don't know if you guys remember, but back in 2010 or so, there was this terrible thing that happened to hundreds of people where they were getting, I think it was spinal injections, but they were compounded and it was for pain. And they were getting them by doctors, but doctors who were using compounding pharmacies, and they died of meningitis. There were like 100 people who died, and I don't remember all the details surrounding it. Well, after that point, it was all over the news. I remember it very well. I was just out of residency, and the FDA kind of got together and said, okay, we got to make some regulations for these compounding pharmacies. And so they came up with these certifications called 503A and 503B. I find it incredibly important that they are one or the other. 503A is essentially kind of state regulated. It means that the compounding pharmacy is making a compound for an individual to be, given from the doctor's office. So that's why they tend to be sent to my office, and our patients pick them up. Versus 503B, which is essentially still regulated, but they are producing bulk. So these sourced facilities have to be 503B. So they really kind of put these regulations. So these are questions you want to ask your doctor who's using compounds. Where are they coming from? What are the kind of safety protocols these compound pharmacies have in place? And I will tell you, because a lot of patients are like, well, they're not FDA approved, so I don't want them. I'm like, well, don't forget, they are FDA regulated. They are FDA inspected. So these facilities have to go through very strict, protocols in order to exist. I find compound pharmacies are like cockroaches in a nuclear warfare. They will survive. They are so amazing at adapting, and they really, really are put under a lot of scrutiny. Versus the online source. I can't speak for it to the degree that I know exactly how they're sourcing, but the question becomes, this is not a pharmacy, because if it were a pharmacy, it would require a doctor's prescription.
Yeah.
And the issue becomes, is it a pharmacy versus a laboratory? And then the next question becomes, where's it being sourced? Because there are no regulations. There's really not any oversight for these onlines. Now, there might be an online where a doctor is prescribing, that's different. But these where you literally can just go through a catalog and be like, I feel like taking this one today, that they're not regulated. There's no oversight to them. So, I just say, tread lightly and, have some caution with those things. You'll also notice on those bottles when you purchase them that usually says not for human use. They have to put that there. That kind of scares me a little bit. So
Yeah.
I don't
Right?
know. Yeah.
Yep. Wow.
Yeah.
Yeah. No, that's great. Thank you.
Yeah. Hopefully that answered your question a little bit.
Yeah, and it's interesting too because like when I think of supplements too, supplements are not technically like FDA approved.
That's right.
Yeah, so it's like you're kind of looking at it, I guess, like a supplement, but most of these too, you have to inject them, right? Versus they're not really
Yes.
necessarily a tablet. So talk a little bit about that, like how do people take them?
Sure. So peptides are really fragile. When my patients pick up their bottles, they may or may not have noticed they're in dark glass. And that's because the peptide bonds are very fragile. If you shake up a peptide, it'll break apart. Light can affect it, can break it apart. So you're not supposed to agitate the liquid. You're not really supposed to put it in light or in heat. In a car, it would be rendered useless because the peptide bonds would break. It's not that you would be harmed. It would just be that you paid a lot of money, because they can be expensive, for nothing.
Yeah.
So, that's number one. So the reason they tend to be an injectable form versus oral form is the stability. You put a peptide in oral form, in a tablet, it has to go through the stomach and be subjected to the stomach acids. Then it has to go through the liver, which we call first pass in medicine. We call it first pass. It goes through the liver and has to be kind of modified and metabolized. And so there is definite debate as to whether the oral peptides work. I know that there is a oral peptide form of, I can't believe I'm blanking on the name of Ozempic. And unfortunately, the patients who trialed that, I felt they didn't have the same results as my patients who had been on actual like semaglutide Ozempic. So, the debate's out there. I have a very good rep at the pharmacy that we are registered with. And he's just such a wealth of knowledge. And they do have some oral form peptides, but he said not all peptides can be placed in oral form. Of course, you're going to have needle shy people, because these are subcutaneous needles, which are very tiny needles, but you just have people who are like, I don't want to inject myself. They just don't want to do it. So an oral form might be the next best option. Its efficacy, though, is questionable, how well they work.
So
So you do the injections in the office then?
No, we actually teach the patient how to do it.
Oh, awesome.
They come in, they pick them up. We educate them on injection technique. It's actually very simple. Just like someone who has type 1 diabetes would have to give themselves insulin injections, we're teaching them how to do injections. Just like we teach a lot of our male patients how to do testosterone injections, because it would just be my office would just be run ragged if we would ever be
Yeah.
So true. So you basically just like pinch the skin, kind of put the needle in the skin, and it's
Yeah.
pretty simple, straightforward.
It's beyond simple. It's so simple. And once somebody who's a little needle shy, if you could convince them to try it, they'll say, oh, that's nothing. I mean, the pinch of the skin can hurt worse than the actual needle because it's so tiny.
Yeah, it's a little
And,
tiny needle.
and what about, like, for example, if you want to inject straight into a joint, if you have, let's say, an injury, shouldn't that go like right into the place of the injury?
Another debated topic. I listened to, and he's a French guy. Of course, he is a name that I can't pronounce. And he's one of like the leading experts on peptides. And he'll tell you that's not necessary. I have patients who have done both and who will tell me anecdotally, yes, they feel that if they inject, like, for instance, a BPC 157, which is for, musculoskeletal repair and regeneration, that when they inject it close to the injured joint or area, they feel it works better than if they inject it in their stomach fat. But remember, peptides know what to do. They get in the body and they're like, okay, what's my role? And then they go find their receptors. They find the cells that they're supposed to, be essentially activating. And so if there's an injury, they know where to go. They will circulate through the bloodstream.
Do you find that people with let's say you need a shoulder replacement, for example. Like I have some friends who have shoulder issues. So what happens there? Like what is the process of healing a joint like that? Like do you do some PRP and then some BPC, and like what is the process of that to try to avoid surgery, I think?
You'd be surprised how many orthopedic surgeons are utilizing, perioperatively, these peptides. I know one in particular. He doesn't live in this state, but he uses BPC when he's about to do a joint, replacement, et cetera, because he feels it accelerates the healing, which I would agree with.
Yeah.
So the way it looks is essentially it depends on the patient, wanting to do those things. However, I like things like BPC for that. I like growth hormone analogs like Sermorelin, Ipamorelin, CJC, because that accelerates recovery and healing as well. So I think it could be used very nicely with, surgical procedures.
Great. And what is the cost for someone, who would want to do that? Like how expensive is it really?
They're expensive. I mean, and I think that's partially why people go online, because they will find them cheaper. I've had patients tell me that, like, doc, I can't afford these in your office. I'm going to go online instead. And I tell them the same thing I told you prior. I mean, at the end of the day, they, have, consumer rights. They can purchase where they want to purchase. However, they can run in the hundreds on a monthly basis. So it can be an expensive habit. I will share with you, however, that they are cycled mostly. I mean, the recommendation is to cycle peptides. And cycling means, you would do maybe a peptide such as Sermorelin for 3 months, and then you would take like a month off. You could take a few months off. And the reason we cycle, or it's recommended, is it's sort of like a knife. If you kept cutting the same knife, what would happen? It would dull. And so essentially, if you keep using the peptide, the receptor sites will essentially dull. That's the best way I can describe it without getting too technical. And it doesn't work as well. So we cycle for that reason. And also patients, another term you'll hear with peptides is stacking. And stacking means using multiple peptides for different reasons. And they're not interacting in a negative way. They're actually interacting synergistically.
So what about the BPC for the gut healing that I've heard kind of people want to take it orally to heal the gut? What is your comment on that?
I actually will tell you BPC is one of the compounds that can be manufactured orally and seems to work. And I find it works best, you are correct, for the gut because it's actually going directly through the digestive system and through the process of digestion to the gut area. So yes, this is one kind of, in my opinion, one of the exceptions. And I also have given patients BPC for joint, issues, and they don't see quite the same results with the oral. But stomach, yes, absolutely improved. It's pretty impressive.
Okay,
What's the
interesting.
timeline of improvement generally? I mean, I'm sure it depends on the person, but
It really does. I would say on the order of, with BPC, it can be very instantaneous. And I really, you guys had kind of told me you might want to talk about some case studies. So I have a few that are pretty impressive. But in particular, this patient that I gave BPC to, she responded within days.
wow.
However, I'd say on the order of, anywhere from a week to months. People are just different. I find the growth hormone analogs like sermorelin, ipamorelin, they tend to, when you see people consistently use them, the response is remarkable. But I find consistency is key with that one.
Got it.
So how do you position yourself with kind of development of cancer? So like, for example, the BPC 157, right? It grows the little blood vessels, right? Which maybe you can link to tumor growth if you have that.
Yeah, everything I have read is that they're really kind of debunking that myth. And that's sort of one of the myths, I kind of don't like, but I have to, as a physician, explain eloquently to the patient. I'm not giving you something that I think would cause cancer, or I just wouldn't do it.
Right.
But, when they look at the actual research and the studies, they're not really finding good data to support it. They're really not. As a matter of fact, if you did and I tell patients, don't do a Google search, do a Google scholarly search, because what a Google scholarly search will do is pull up all the articles out there. And just because it's in a medical journal doesn't mean it's a good study, by the way. So I say that,
Right.
take that with a grain of salt.
Yeah.
We saw what the Women's Health Initiative did to hormones, and that was one of the worst studies ever conducted. Even the researchers have come back and said it was a terrible study.
Oh,
So the actual lead investigator said that.
oh,
But I think, when you look at do a Google scholarly search on, you'll actually find quite the opposite. Because one of the ones that I hear the most about cancer causing is the growth hormone.
yeah.
So you have growth hormone analogs. I don't write for actual human recombinant growth hormone. It's not that I think it is bad. It is that it is so federally regulated, and it is a peptide that is pharmaceutical and FDA approved. But it is so federally regulated that if you are giving it off label to one of these drugs, that if you give off label, you will be under the radar of the FDA as a physician. So I caution my patients on that, because I will get patients who come to me and say, hey, can you put me on this? And I'm like, unless you have dwarfism or adult growth hormone deficiency, which is incredibly rare. I maybe have had one or two patients with that. Then no, I won't. And the other reason I don't like to use actual recombinant human growth hormone is because it is attached to the receptor constantly. And that's not how growth hormone works. Growth hormone is a pulsed hormone. It turns on and it turns off. Okay. Mainly at night, because we're sleeping and we're repairing. So growth hormone kind of gets secreted for our repair mechanisms. That's why sleep is so important. One of the reasons. So, I'm very cautious with that one in particular. I think I got on a tangent and got away from your question. I'm so sorry. Oh,
No, no.
growth hormone's the one that gets, kind of the bad rap for causing cancers. And again, if you do a literature research on that, you will not find a lot of evidence for it at all.
Interesting. Yeah,
That's
I was listening to Huberman talking, and he was actually going into the BPC 157. That's what he was saying.
Oh, the angiogenesis.
Yeah, that could promote tumor growth, he said. But yeah, because of the blood vessels, that you basically forming more of the little small blood vessels.
I think the jury's still out. Again, you're going to find articles that support that it actually regresses or kind of turns off cancer cellular growth with cancers. That's one of the articles I read about with the transcription factors that it inhibits that. So I think again, these are kind of like such not debatable per se, but really research has not really lended itself to a lot of studies on these peptides, and hopefully going forward, we're going to have a lot more information. There's not a lot of money in peptides from the FDA standpoint. Excuse me, big pharma standpoint. I'm sorry, they're kind of incestuous. They're kind of very
Yeah.
much bed
Yes.
together because big pharma, as you know,
Yep.
funds a lot of the FDA. So it's hard to trust when you have that kind of relationship, going on. But I think in all, there'll be more research that comes out. But the funding is what we struggle with research on these kind of things like peptides.
Yep.
interesting. Amazing. Well, tell us a few studies or stories that you
Yeah.
have from your patients. We'd love to hear, how people are using it. I think probably our listeners would be most interested in that. Like, what do we do? Like, if I go into your office, what would you give me, and how would it be for, and what symptoms would it help?
Yeah. And hundreds of people I've seen peptides benefit. One particular case stands out in my head, a woman who had basically plantar foot pain. Okay. It wasn't plantar fasciitis. They couldn't figure it out. I mean, and she was a runner. She didn't have any stress fractures, and she was debilitated by this pain, in both her feet. And she basically, a lot of times I'm called resort medicine. I don't know if you guys have ever heard that term, but they call the type of medicine I practice, like functional medicine, regenerative medicine, age management medicine, they'll call it resort medicine because people will come to you as their last resort. And she had done that. She had gone to Mayo Clinic. She had seen doctors, podiatrists, everything, and nobody could figure out this foot pain. And I mean, it went on for years. She stopped running. She just couldn't be as active, and she was miserable, and she ate well, and she did everything right. And she came to me, and she had already done her research. And so a lot of my patients come with kind of their research done. And she said, I really want to try this BPC 157. I'm hard pressed to find a doctor who has, a relationship with a compounding pharmacy that can make it. And I would like to try it. So she tried it. And within 1 week, I checked in on her, and she said to me, it's gone. And I take that back. She said it was significantly decreased, maybe like from a 10 to a 4 or 5. I said, okay, great. And then months later I saw her, and I said, how's everything going? She said, great. And I said, what's your pain scale? And she said, it's gone. And I said, no, I mean, you must have a little bit left. And she said, I have nothing. It's gone. And then she actually, and this is actually a very important part because people think they have to be on peptides forever. And it's not necessarily true. She did the BPC for a good, I want to say 3 to 4 months. And we talked about cycling. I said, why don't we take a little cycle off of it? She was reluctant because she was so happy by her improved pain. And I said, just let's give it a shot. We can always go back. And so she did. And the pain never returned. So, that's one anecdotal story. Of course, it's just a case study. It's not like a randomized controlled trial or anything.
Right. We're hearing a lot of that though, like just anecdotally, the people that we've known who have tried this, they're like, oh my goodness, I am completely better. Like it's just kind of a wild thing. It's like,
oh yeah. And I mean, some really wonderful ones have been taken off, the FDA has kind of, they put a lot of restrictions, like I said, on these peptides. They've taken some really good ones away, like thymosin alpha. It was so great for viral illnesses. I mean, they were using it with, in studies on COVID. And all of a sudden it was just like, nope, no longer can you make this. So I said, these compound pharmacies are held. They basically, here's my theory. And of course, I don't want to be conspiracy theorist at all, but my theory is they compete, these compounds, these peptides, which are made from compound pharmacies, these compound pharmacies really compete with big pharma.
Yeah.
And I don't think, and big pharma is a $45 billion industry. And I
Wow.
don't think they want any competition. So they snuff out the competition. They fund the FDA. They let the FDA run around and put their thumb on all these compounding pharmacies. And what they do is they go around, they change the nomenclature of the peptides. And they start saying, you can't make anything over, I'm just making up a number, 30 amino acid sequence. And they start
Wow.
making these kind of rules and regulations. And then that makes like, thymus and alpha's got to go. And also, by the way, you'll notice this different state to state. Because these are the like I said, the 503As are regulated by the state pharmacy boards. So but don't kid yourself, the FDA is regulating those. So it's just a disaster because there's so many health benefits to these things, and they kind of pull out this whole, there's safety issues, this and that, but they don't prove any safety issues. They don't
Yeah.
really actually present the data. So that's an issue for me. It's like, well, if you're going to say there's safety issues, I want to know as a doctor, is there safety issues? And
Right.
again, they don't provide the data to support that.
Maybe they want to turn them into drugs. They take them off
Yes.
yeah.
They
Money.
do. Oh, they do. Oh, they absolutely do. I mean,
That's
and the
it.
beauty, Ozempic and Mounjaro, and these drugs are very, very good. I mean, for the weight loss, and they like I said, they're naturally occurring substances. The GLPs, the GIPs, your gut secretes those in response to food. And so as we age, our peptide levels decline, and so we're essentially kind of adding back what we need. I always tell my patients, like vitamin D, for a vitamin D deficiency, you're kind of giving back what you already had at one point and, robust levels, and now it's declining. So, they are, that's a big fight with the compound pharmacies, because the compound pharmacies, since it's a peptide, figured out how to synthesize it. And the way they got around the basically patent on the drugs like Ozempic and Mounjaro is they put in a vitamin, like a benign vitamin, like B12. And then that's the beauty of compounding. They get to say, hey, it's not the same drug.
Wow.
Yeah.
Yes.
And so that's how they get away with it, because B12 is not going to hurt anybody. So I say, I talked to my, pharmaceutical rep, Adam, he's so great. And I said, what do you think about all that, Adam? And he goes, I think compete with us. Stop making your drugs so expensive. I mean,
Yeah.
these drugs are $1,200 a month out of pocket. So he said, just compete, don't make your drugs so expensive. You won't have to worry about us. And he's totally right.
Yeah.
What
Wow.
do you say to the people that, and I bet you've treated a lot of people with, let's say, obesity, and you put them on Ozempic. What is kind of, if you go on Ozempic, is that like a forever thing, or what happens if you stay on it for a long time?
No.
Is that something you recommend, or what is the protocol?
Well, here's the deal. Ozempic and Mounjaro are FDA approved for diabetes. So anybody who's using it for weight loss is technically using it off-label. But the beauty of off-label use of drugs is that it's completely legit. You go on the FDA's website, they even have an entire statement piece on off-label use. They say we don't take away the art of medicine, that, providers have the right to, if they see fit, a use of a medication that's outside its original indication that would benefit a patient, they can use it. That's what off-label use is. And so a lot of people are using it off-label, although they do have now Zepbound and Wegovy, which are for weight loss. The biggest issue is coverage. So for those patients of mine who don't have coverage, great. We go with the pharmaceutical grade. For those who don't and want to use the compounding forms, which are semaglutide and tirzepatide, which is the compound name of those drugs anyways, they do. And I use it for many different ways. I do have diabetics using it. I have those using it for weight loss goals. And I have patients who, when they hit their weight loss goal, I usually kind of discuss coming off the medication. One, their wallet will like me because it's expensive.
Yeah.
It's still expensive, and no way you can cut it. It's still expensive, but they also don't necessarily need to be on it long term. I'm not even so sure diabetics do either. I mean, if you really kind of reverse your diabetes, which you can, you shouldn't necessarily need to stay on Mounjaro or Ozempic the rest of your life. I do have some patients who use it for maintenance, meaning they've hit their weight loss goals and now they're using it for, once a month or every 14 days instead of every 7 days. Maybe they're using smaller doses. The beauty of a compound version of these drugs is you can titrate your dose. Whereas with the commercially available drug, like, Ozempic, you're stuck with the dose that's in the pen. That's it. It goes up incrementally and you don't have any in-between doses. Whereas with the peptide, you can, instead of jumping 25 units, you can go up 5 or 10. So the patient can kind of titrate their dose. Negative side effects or negative press surrounding these drugs are things like pancreatitis, thyroid medullary cancer. Really not, I've been using these drugs for years, never ever seen it. I wouldn't give it to someone with a history of thyroid medullary cancer, and I would not give it to somebody with a family history of that. Although if you ask a room of 100 primary care physicians, how many of them have ever seen thyroid medullary cancer in their career, you might see one hand go up. It is insanely rare. So those are kind of the big things. The worst side effects I have seen with this drug, and now that I'm using it years, it comes with a big disclaimer from me, is muscle mass loss. You will lose muscle mass only if you don't eat enough protein, which is hard. When you're on this drug, it suppresses your appetite. So you will lose muscle mass if you don't eat enough protein. And so like a 110-pound woman, 115-pound woman, I would like her to get in 110 to 115 grams of protein. And that is very difficult if you've ever tried these drugs, because your appetite is so suppressed and you just legit cannot fit that much food in. And then secondarily is resistance-based training, not just cardiovascular, which I don't negate the power of cardio, but I think the power is in resistance training for body comp changes. So that it comes with a big disclaimer from me. I always tell patients more is not better with these drugs. Because some people will be like, I just want to go up on dose. I want to go up on dose. I go, well, what's going to happen eventually is you're just going to sacrifice your muscle mass. So you, instead of fat loss, you're going to have muscle mass loss. But so that's essentially what, I tell my patients regarding these GLP peptides.
Yeah,
Amazing.
very informative. Fantastic.
What about
'Cause
women who are like I get a lot of clients who are, maybe they want to lose 5 pounds or like 10 pounds. So like, what would you say to someone like that? Is that an Ozempic situation, or is it really more for people who are like full on diabetic,
Yeah, I prefer not. I mean, if I have a woman who wants to lose 5 pounds, I'm going to really take a deep dive and evaluate her diet, her exercise patterns. In our office, we have a body comp scale called an InBody, which is a bioelectrical impedance scale. So we can kind of see, it's not the most perfect measure for body composition, but it's a great trending device. And we can really see, oh, is this woman really just under muscled? What does she need to lose? Does she need to lose fat? So that's kind of how I would evaluate a patient there. I mean, have we ever used drugs like tirzepatide and semaglutide for a woman like that? Yes, but they always are told very, very low doses, and please, goal oriented, meaning once you've hit your goal, we'd really like you to kind of come off of it. So that kind of person, I mean, I'm someone who utilized it years ago. I had gained close to 17 pounds, and I'm a small person, and I could not get it off. I mean, I was struggling. I come from actually a family history of diabetes. So I have kind of a inclination towards insulin resistance. And I took this medication, took tirzepatide, and within, I want to tell you, 6 to 7 weeks, the weight was off of me. And I'm someone who's really never gone back. I mean, I kind of have it in my fridge. I make a joke. It's like Xanax in a purse. It's there. And it's there. But I don't really, in the years that I lost that original weight, I've maybe gone back to it 2 or 3 times. And when I say gone back to it, I've just taken one dose, and a very small dose. So I do find those drugs are a little size dependent. So smaller people usually need much smaller doses. And bigger people who have more weight to lose tend to need higher doses of the drug. The drug goes from tirzepatide, for example, goes from 25 units to 150 units. And I don't have many takers on the 150 unit because the side effects of nausea, queasiness, even vomiting, bowel irritation is too much for people at those doses.
Yeah. That's good. That's important to know.
Yeah.
Mm-hmm.
Amazing. Well, what else do you want to tell us about peptides? Any other good stories besides the foot?
Oh, well, I do have a great story of patients who's stack peptides. Okay. There
Oh
are a
yeah.
couple. And they, sought out to lose some fat. And they came to me already on tirzepatide. So they had already kind of been on Mounjaro. They were losing the weight. And then it really kind of the focus shift became body composition change. I want to say the husband started at 26 or 27% body fat, which is relatively high for a male, just so you know. The female started in the 30s for percent body fat, maybe I'm guessing 34, 35%. Both of them started, with the Mounjaro type of drug, the tirzepatide GLP peptide, and then started stacking their peptides when they came to me and started doing like sermorelin, the ipamorelins, the growth hormone peptides. And I will say they both have impeccable diets. They work out. They didn't always. So they really made a full-on lifestyle overhaul here.
Yeah.
And he walked in my office the other day at 8% body fat.
Wow.
She is sitting at, I want to say 14 or 15% body fat, and they look phenomenal. And I like them as the example, as you do not have to lose muscle mass with these GLP drugs. That is not like, oh, it goes hand in hand. I think they are just kind of like the poster children for doing
Yes.
it right, you know?
So I think they are my friends
Oh,
that you're talking about. Yeah,
no.
exactly. I won't say that, but
Although I have to say, I do have multiple couples like this. So who the heck knows? And we,
yeah,
I know for your podcast listeners, they may not realize, in every other town in the US, everyone's 7 degrees,
yeah,
apart. We're
separation.
in
Yeah,
Vero, it's half a
yeah,
degree.
exactly, exactly. You
Yeah,
know what?
everybody knows
I'm just
everybody.
saying that it might not be them, but I can only think they are like Barbie and Ken right now. I mean,
Yeah,
they're
yeah,
gone from being like you said. I mean, like I guess average to now
yeah.
it's like like it's head turners
It
basically.
it is, and they look good because, and
Oh,
again, I don't know if it's the same one because I do have 2 others, and it's funny, it's a husband, they're all husband wives, and it's amazing because I think they just, motivate each other. It's so
yes.
nice to do something as a unit, as a team,
Mhm.
and they motivate me. I mean, I sit there and like study them. I'm like, okay, so what did you eat? What did you and I
Yeah.
sometimes like, why is she so incredibly interested in this? I'm sort of interested for myself, you
Yeah,
know?
exactly.
But anyways, I
Yeah,
think you can really do well. So I kind of, when I listen to the news, and the news loves bad news. I mean, let's
yes,
just, good news does
yes,
not sell,
yes.
minutes.
Yep.
And so they like to sensationalize these drugs, and it's causing this and bowel obstructions. And listen, I'm not saying that's not possible, but these things they're describing are happening at much higher doses.
Yeah.
We aren't playing with that, in my office. Also, everybody who comes through our office, we don't just go, here's the drug. You are getting an entire lesson on diet, an entire lesson on exercise. We're
Mm.
looking at your metabolic health. We're doing comprehensive lab evaluation. We don't treat this like willy-nilly, So, and I'm not knocking other doctors, but there are doctors just literally writing for this and being like, whatever, go do what you want to do. And that's a problem.
Mhm.
Mm.
I
Mm.
love the idea of like these couples doing so well together because it's such a testament to community, right?
Mhm.
Like how you heal so much better in an environment where everybody's kind of doing the same thing. And
Yeah.
It is so true. And I mean, these other couples are also, and these people I'm talking about, are also doing hormone optimization, if they're testosterone deficient, now they're not, progesterone, estrogen balance, all of those things. So there, like I said, it is sort of like a big pie chart, and peptides are, a piece of the pie. They're not the entire thing, but they are such a great adjunct to a healthy diet, lifestyle, exercise pattern, hormone optimization, metabolic health. And they, also from the standpoint of reversing, we call anti-aging, and people kind of roll their eyes, or, my colleagues I know sometimes will roll their eyes. Anti-aging just means we're slowing the progress. Every single one of us is going to die. The hope is that we don't have an accelerated path to, that final outcome.
Yes.
Yeah, and we wanna live your life to the fullest too, and you wanna be as healthy for as long as you can without, even if
Exactly.
you're, like, still playing tennis when you're
Yeah.
80, like that.
Exactly. You want to remain functional. Exactly. So there's some cool peptides like on the horizon. I know you guys wanted to chat about that. There's one, it's that's in development. I think it's in its clinical trials, and they're partnering with Eli Lilly because Eli Lilly owns Mounjaro, and Mounjaro is tirzepatide, and it's like called apelin with tirzepatide. Essentially, it's going to be a peptide that helps prevent the muscle mass loss, which is going to be such a game changer.
Wow.
Because I will share with you, as much as I know and knew about this drug, I still lost a little bit of muscle. And to put back muscle, when you're in your 40s and 50s is not an easy task.
No.
So, the hope is to not allow the patient to lose any muscle because that would defeat the entire purpose. I mean, muscle is your sort of your longevity tissue.
Yes.
And it helps with your metabolism in general, just as far as, like, avoiding diabetes and,
Absolutely.
people don't
Mhm.
realize that eating enough protein and, lifting instead of just doing so much, running and biking and those
I
things
know.
are great and wonderful, but especially for women, I think too, we're trying to avoid like osteoporosis and all those things. So
Absolutely.
So
yeah.
Absolutely.
true.
And it
Oh,
looks
agreed.
healthier and better too, I think. But I guess,
Oh,
Yeah.
yeah.
yeah. Um, but Dr. Hockey, I mean, how, Molly, do you have any more questions or?
I kind of actually wanted to ask a hormone question, if that's okay. I know we've been focused on peptides, but I know you do hormones as well. So,
Yeah.
so could you talk a little bit about hormone therapy for, especially for women and women who are transitioning into that menopausal stage?
Yes. Absolutely. It's kind of my wheelhouse. I love hormone therapy and hormone optimization. Unfortunately, hormones got a little bit of a bad rap in the late 90s, early 2000s. There was a very large study conducted, probably one of the largest studies ever conducted. And then it happened to be on hormones. And they were kind of it was called Women's Health Initiative. It sort of kind of gave a bad rap to hormones and felt that hormones were causing an increased risk of breast cancer, and they stopped the study short.
Right.
And if you look back on that study, and that's an entire podcast by itself, by the way, and there are entire books written on how poorly conducted that study was and how, there were just a million reasons that it was not a great study. There's even been the lead investigators on podcasts talking about where the study flaws lied. So unfortunately, that kind of resonates in everybody's brains to this day. Still, I still have patients saying to me, don't hormones cause breast cancer? This is not factual. Actually, there's a reduced risk of breast cancer when hormones are done properly, and bioidentical hormones mean natural hormones. So in my office, we tend to use bioidentical hormones. Most associate that with compound pharmacies, and I tell them that is not true. There are compound pharmacies that can compound hormones, but you will also find bioidentical hormones in your Publix, in your CVS, in your Walgreens, because estradiol patch is a bioidentical. It is a natural hormone. Progesterone, natural progesterone is what it literally says on the bottle when you pick it up from CVS,
Yep.
because that's what I'm on. And it is a natural progesterone. It's not synthetic like MPA, which, by the way, was used in that study. In any event, if hormones are done properly, and you do have a window of opportunity for hormone optimization, in particular with women. So women kind of approach menopause, and we are just robbed of our hormones abruptly. And it does happen kind of overnight, but it leads into it. So it can be a 7 to 10 year process. A lot of women 39, 40 are already starting with perimenopausal symptoms. You would evaluate their hormones, and you can actually start hormone therapy safely. A lot of women in the perimenopause period, meaning approaching menopause, they will drop progesterone levels, and it will present as they're more anxious. They have more water retention. They can't sleep. They're waking up in the middle of the night. They have very superficial sleep, weight gain. So they'll present like that, and you give them some progesterone at night, and their symptoms tend to dissipate. And then eventually we start dropping estrogen as we really approach kind of the menopausal point. And that's when you can replace estrogen. And benefits of estrogen are cognitive health and muscle mass, and actually decrease fat. A lot of people associate estrogen with fat gain. That's not true. It's actually the loss. So you can do it properly, and you always want to find, and I'm not saying not tooting my own horn or anything, but you do want to find a doc who's trained in hormones. I always make a joke. It's sort of like a sexy medicine to do, like longevity medicine, but it's like, okay, but where did you learn it? It is not a cavalier type of medicine to dabble in. You really need to know how to follow numbers. You need to know how to follow ratios of these numbers, listen to your patients, listen to their symptoms, and approach each person as an individual.
Yeah,
No.
that's amazing. Yeah. So, and as far so I'm a functional diagnostic nutrition practitioner, and I can recommend like supplemental progesterone, like a Quicksilver progesterone, or like a Estadap from Biomatrix, that kind of thing. And I just see like major changes in people's personalities and people's like how well they're able to even stick to protocols and stuff if you get them on just a teeny bit of hormone, just a little bit. How do you guys test? Do you use blood? Do you use a Dutch test?
We use blood for the main reason. This is so debated at every conference I go to. I just went to a big bioidentical hormone symposium in Miami. At every conference I go to, all the speakers, are usually physicians and nurse practitioners who are pretty, well versed in the hormone field. They will debate. They will. The salivary is the best. The Dutch is the best. The blood, and they go back and forth. We use blood, and I'm going to tell you why.
Yeah.
It's the way we get our patients to be most compliant. I'm going to be honest. You're not going to get a lot of people to do the Dutch. They have to pay out. I've done the Dutch, and I think the Dutch is wonderful, especially for seeing the metabolites of the hormones, but you're not going to get a lot of people to do it, and they have to pay out of pocket. They want to use their insurance for their labs. So I'll be very frank. We use blood testing. But that the jury is out on which is the absolute best testing method. That is for sure.
Yeah, I find that too. Everyone has their own theory, and it's never,
Yes.
it's never
Mine is compliance.
Yeah.
I want what they're compliant with.
Right. It's so true. Well, Alex, do you have any other questions?
No, I think this was great. This
Yes.
is we covered a lot, and I think the listeners learned a lot as well, and I learned stuff that I didn't know, and I think it's wonderful. How can our listeners find you, Dr. Haake?
Well, we are Regenerative Biologics Institute. You can do a quick Google. It doesn't have to be Google scholarly, but we're called RBI, verobeach.com or Regenerative Biologics Institute. We're kind of a multifaceted facility. We have stem cells. We do, the concierge medicine myself and my husband do. And then we have a nurse practitioner who has a wellness program for those patients who don't want to go concierge. And we have aesthetics. We have an absolute rock star aesthetic team. So we're a fun facility to be at and to work. And I am happy to work there, to be honest.
Oh, wonderful.
And stem cells, we could do another whole podcast on those too.
Yeah, I have the guy for that. Jason Griffith is our stem cell scientist. He's, the owner of RBI, and he is a world of knowledge. You would just love talking with him and picking his brain.
So, Dr. Haake, what type of stem cells are you using? I know you're restricted in the US. I just got involved with a stem cell company outside of the US.
Yeah, we use fat derived, autologous, so from the patient.
Okay.
Yeah, that's we feel
That's a whole different podcast.
What's that? Yes.
That's a whole different podcast, right?
I know. I have the people for you. Just let me know and I'll line it up for you.
Yes. So exciting.
Yes.
Oh, that'd be great. Yeah, because that's
yes.
another thing for healing joints and all of that too. So that's another whole discussion. But yeah,
exactly.
Cool. You guys have a lot of amazing tools and resources at your fingertips. So I think you might get a lot of calls after that.
Oh, yeah. Thank you. I thank you for allowing me the time to speak about it. I'm very passionate. I love this type of medicine. So absolutely anytime.
Thank you so much, Dr. Haake. Have a lovely weekend.
You too. Bye-bye.
Thank you. Bye.